Okay, welcome everyone. I think we can get started now. So thank you for coming along today for another ANZ GIN webinar. It's part of the ANZ GIN webinar series. Today myself is Heath White, and Kelvin Hill will be discussing the living guidelines approach and discussing whether it's both achievable or if it's sustainable. So before I get into it, I would like to acknowledge the traditional owners of the lands on which we meet today, which for myself in Melbourne is the Wurundjeri people of the Kulin Nation. And in Adelaide, where our webinar is actually being hosted, it's the Kaurna people of the Adelaide Plains. And I'd also like to pay my respects to their elders past, present and emerging, and also welcome any Aboriginal and Torres Strait Islander peoples with us for the presentation today. So thank you for joining us today. We have quite a bit to get through, so I won't dwell too much, but to get most out of this webinar, we have actually added you all into listen only mode. However, you are able to interact via the chat and also via the Q&A functionality as well. If you do send messages via chat, if you could please make sure that both panelists and people attending the meeting actually receive the messages so that we can all see what's happening in the chat. That would be fantastic. And also a recording of this will be available on the JBI YouTube channel following the event. So please send some feedback as well to a-nz@gin.net. Also during this webinar, if you do feel like tweeting, then please by all means feel free to do so, #ANZGinWebinar, and we'd love to see any tweets that come throughout the webinar. So today we'll be discussing living guidelines and to, as I said, mention whether they're actually achievable and sustainable. So my name is Heath White. I'm the Deputy Director of Evidence and Methods at the National COVID-19 Clinical Evidence Task Force. And also the Evidence Lead for Living Evidence for Diabetes program at Cochrane. And I'll be presenting with Kelvin Hill, who is the National Manager of Clinical Services at the Stroke Foundation. So first, what is living evidence? At its most general term, it's an innovative means by which systematic reviews and associated guidelines are updated continuously to ensure high currency of information. And I emphasize the innovative because it's not just simply using existing methods and just doing it more rapidly. It's actually optimization, evolution of methods to make sure that we increase the speed and decrease the workload required to update the guidelines, while also maintaining high quality of the resulting recommendations. So one of the questions you might ask is, why bother doing living evidence? And for us, we've identified some problems with traditional guidelines. There's several, obviously there's many good guidelines out there, but they all suffer from some problems, such as high initial resource requirements. So some of them can take hundreds of thousands of dollars and years to produce. As you can see from defining the scope all the way through to publication dissemination, it can take a very long time. And during this time and following publication, when it's actually in this implementation phase, there is a reduced currency of clinical evidence over time. So one of the studies we've seen did guideline survival analysis and determined that 1 in 5 recommendations is outdated after 3 years of guideline publication. And so obviously the currency diminishes quite rapidly over time. They're also unable to adapt to changes in policy and practice. So if there is a change in policy and practice, if there's a therapeutic that was previously too expensive to actually afford, and so you couldn't really give a positive recommendation supporting its use, suddenly is funded now by the government, that's not captured in the guideline either. You have to wait until the next iteration of the guideline to capture that information. And also updating existing guidelines can be wasteful as well. So if you're updating a big guideline with 200 recommendations, the majority of those won't actually change and won't require an update. So you're actually looking for research evidence where there is no new evidence as well. The living evidence approach, so it's low but consistent expense. So if you are starting from scratch, you'll still need to develop the full guideline. But then once you actually develop the guideline, we do what we call walking across the plateau. So every month or 2 months or however frequently you want to update, you just have a low consistent expense where you search, incorporate any evidence, and then publish the updated recommendations. This ensures that you maintain high currency. So if there are any changes in policy or practice, any new products to market, etc., they're captured far more quickly and incorporated into the guideline. And one of the things that I really like about it is that it can evolve through feedback mechanisms too. So it's not just the updated evidence, because the guidelines, for instance, the diabetes task force guidelines and stroke guidelines are published within a platform called Magic App, they're open for permanent public consultation. So people can comment, suggest changes and updates at any stage, and we can incorporate that feedback into the process. So the first thing we ask, as the NHMRC guidelines for guidelines put it most well, is to adopt, adapt, or start from scratch. So obviously you can adopt an existing guideline or you can develop one anew. And if you choose to develop one, it can be a full guideline or you can do select clinical questions. So Kelvin and his team at the Stroke Foundation put together a full guideline and use that as a template for living evidence, whereas the diabetes team, myself, selected specific clinical questions that we thought fit the living evidence paradigm and chose those to actually make living. And so as you can see here, once you've determined which recommendations should be living, then you update the search strategy, execute it, update the living systematic review. If there is substantial new evidence, then you can update the recommendations. If there's no substantial new evidence, then you can just go back to the drawing board, revise the scope based on any stakeholder feedback, repeat the search and wait until there is new evidence available. So the question is to be or not to be. To be eligible for living guidelines really needs to be a high priority question. There needs to be uncertainty in the strength or direction of the recommendation. And there needs to be a likelihood of new relevant evidence being published in the near future that may change the strength or direction of the recommendation. And so Australian Diabetes Society and others consider that diabetes did fit the bill for these. So there was an Australian National Diabetes Strategy in which they suggested the development of Australian government approved guidelines for all forms of diabetes, prevention, early detection, management, and also that there is no NHMRC approved guidelines for diabetes treatment or management within Australia. There was one approved when we started the project, but as of August last year, it's no longer approved. It's reached the 5-year threshold and it's no longer NHMRC approved. So we've had a reliance on American Diabetes Association and Diabetes Canada guidelines. And there is quite a bit of uncertainty around several components of diabetes, such as hybrid closed loop systems, therapeutics for the treatment of type 2 diabetes, etc. And there is a lot of research happening in this field as well. And so a bunch of diabetes groups got together. So the Australian Diabetes Society, Australasian Pediatric Endocrine Group, Australian Diabetes Educators Association, and also Diabetes Australia, along with some people from Cochrane, Monash, RACGP, and Department of Health, to form a steering committee and to develop a project in which we can demonstrate the potential of living recommendations in priority areas of diabetes. And so the steering committee took what is a massive body of work, looking at all forms of diabetes prevention, diagnosis, and treatment, narrowed them down into a few specific topics that we thought would focus on for the first demonstration project, which is technology for the management of type 1 diabetes and therapeutics for blood glucose control. And then we established guideline development groups, which actually came up with the specific clinical questions. So I won't go into too much depth here, but we did develop quite diverse guideline development groups for both of these topics. As you can see here, it actually took 3 weeks for the final selection of PCOs in the technology guideline development group. There were 17 proposed, they went with 6 to end with. 4 of these, there was an existing systematic review which met our inclusion criteria and which we adapted, whereas for 2 of these, there was no appropriate review identified and we had to start from scratch. For therapeutics, it took a bit longer. So we still had quite a diverse guideline development group. It took 7 weeks to select the final PCOs. 23 proposed, we went with 4 final PCOs, and most of them were kind of metformin or other second-line therapies for the treatment of type 2 diabetes. And for 2 of these, so looking at glucagon-like peptide receptor 1 receptor agonists, sodium and glucose transporter 2, and dipeptidyl peptidase 4, that we identified a review with the New Zealand research group, and we actually worked with them to actually develop a network meta-analysis for this topic. So one of the big things about living evidence is the use of technology to actually streamline the work that we do. So once we've done our searches from our PubMed and central databases, we import that into Confidence. And this is a platform whereby you can do total abstract and full text screening, extract the data within Confidence, and also conduct the risk of bias assessments, and then export that into Cochrane RevMan for data analysis. For this, we use Cochrane RevMan 5.4.1 because RevMan Web does not actually play nice with MagicApp at this stage. But once that's finalized, we import that into MagicApp, develop the evidence profiles, and then present this to the guideline development groups so they can help develop recommendations. So we finalized the first baseline recommendation. So this was obviously our starting point before we can even get to living evidence. You can see we had quite a few conditional recommendations. For the most part, it's using continuous glucose monitoring over self-monitoring or pinpricks, and the use of insulin pumps over daily injections was 2 of the big recommendations. As you can see here, metformin is still the gold standard in initial therapy. So everybody thought it was the gold standard, but we did a comprehensive analysis to confirm that is indeed the case. And also SGLT2s and GLP-1s are the best add-ons for people with existing cardiovascular disease or kidney disease. And down here you can see that sulfonylureas and thiazolidinediones are less effective than the alternatives, and so we had conditional recommendations against their use. So current status, this guideline has been approved by NHMRC Council in the 4th quarter last year, so it's officially received a tick of approval. The Magic App version of the guideline is live, so please feel free to hop onto Magic App and have a look and review our recommendations, leave some feedback if you so consider it fit. We have actually distributed a communique to key stakeholders through a targeted email distribution following publication of this guideline. And also, as you can see here, the Australian Diabetes Society has actually incorporated living guidelines as part of their homepage. So if you want to go to the ADS website and find out more about the project and get links to Magic App and so forth, then please go to the ADS homepage and you can find more information there. The transition to living mode. So we have transitioned to living mode. We have updated the technology search and recommendations twice. The first time we identified 4 new studies for 2 of the PICO questions, 2 of the clinical questions. We updated the evidence, but there was no change to the strength or direction of the recommendations. And also for the second update, we identified 2 new studies for 1 PICO, and that was the use of closed loop systems. Updated the evidence, there's still no change to that PICO. So we have expanded the scope. We're now looking at continuous glucose monitoring versus self-monitoring or pinpricks in adults using insulin pumps. And for therapeutics as well, we're currently updating the network meta-analysis. So we did identify 32 new studies. One of them was quite large. However, this was from a base of, I think we had about 730 RCTs included in the original analysis. So even though there's 32 new studies, there's no anticipated change to the strength or direction of recommendations in that component at this stage. So in diabetes, we have learned some lessons, obviously. Living evidence is quite a new field. The methodology is evolving quite rapidly. One of the things we've looked at is thresholds for updating. So whether you find a study that you think might change the strength or direction of the recommendation, do you hold it off and put it into surveillance mode until we have additional data that may change the strength or direction, and then only look at the combined data once that happens? Or do you update the evidence base as and when you identify every single study? Another one was when to reconvene the guideline development group and maintaining engagement. So obviously, if you only have 1 or 2 studies that you think won't change the strength or direction, is it worth getting the group together just to say, we've found 2 new studies, there's no change, thank you, see you next time? That might not be worth their time. And also maintaining engagement, because when you develop a traditional guideline, obviously, you have got the group together, you go through the whole process of formulating the recommendations, having it published, and then they disband. Whereas with living evidence, the group never disbands. It's always required so that you can engage with them. Also publication dissemination as well. We're still working out ways in which we can communicate our updates to members. And also increasing understanding and acceptance of living guidelines was also kind of a bit of an issue, because obviously it's still quite new. So when we tell people who are doing research in diabetes or clinicians with diabetes, they'll often ask, well, why do a living guideline? What's the benefits of doing this approach? And so we have to kind of increase acceptance and awareness of the methodology for them. And also to consider the prospect of expanding the scope to save on time. So originally, if you recall, we looked at continuous glucose monitoring versus pinpricks, and that was in people using injections. And now we've expanded the scope to include patients that use insulin pumps. But when we first did the project, obviously we only included those studies that fit the initial inclusion criteria and excluded those studies where they were looking at patients using pumps. So now we've had to go back and rescreen to kind of identify those studies. So if you can tag specific studies along the way, and I know Confidence does have a tag functionality now, then that could save some time too. And one other big thing we have learned as well, which I'm sure a lot of you have also learned, is that pandemics can be disruptive. But on the other hand, pandemics do also provide a fantastic exemplar for the living evidence strategy. So it is definitely a high priority topic. There's significant uncertainty in the strength or direction of recommendations. There are no recommendations out there because it is brand new. And of course, we've seen the biggest explosion of research in history looking at ways to treat and combat COVID-19. So there's a very, very high likelihood of evidence being published in the future. So as a result of this, Julian Elliott and colleagues at Cochrane Australia developed the National COVID-19 Clinical Evidence Task Force, which I've been involved in since March of last year. So it was formally established the 23rd of March. The first guideline was actually published less than 2 weeks after that. So we hit it quite quickly to try and get on top of it as soon as we could. It has 32 member organisations covering primary, acute and critical care settings, and they comprise 16 expert panels with over 250 individuals that contribute to reviewing the evidence and developing the recommendations for us to publish. And with over 360 hours of volunteer time per week, we're probably over 20,000 hours of volunteer time since inception of the task force. And we do this by having a very high throughput system. So from inception, we decided that we're going to have a high throughput system to make sure that we capture this evidence and get it out to the public as soon as we possibly can, while still maintaining rigor. And so we did daily literature searches, and we continue to do daily literature searches, screen the publications, we do quality appraisal and data extraction on those, and then develop evidence profiles within Magic App. And we present those evidence profiles to the guideline panels for review, and they come up with recommendations and flowcharts. That used to be weekly, we've moved to fortnightly now. But following the formulation of recommendations, this goes to the guideline leadership group. And if they approve it, which they generally do, it goes to the steering committee 2 days later, and then the following day it's published. So for some of the larger topics as well, such as the corticosteroids, hydroxychloroquine recommendations, so when the large studies are published, from identifying the study to actually publishing the updated recommendation is often under 3 weeks. And so I'll just share with you the disease-modifying treatments status at the moment. So as you can see here, the first time we published this guideline on the 3rd of April, we had a single recommendation for disease-modifying treatments. And that was just a consensus recommendation saying they should only administer antivirals or other disease-modifying treatments in the context of clinical trials with appropriate ethical approval, because there was no information out there. As you can see, as time passes and we get further and further into our version numbers, we have more and more recommendations looking at disease-modifying treatments. And so we have well over 100 RCTs included in these recommendations. And we've ended up with 66 recommendations at this stage, looking just at disease-modifying treatments. And it's important to note here that it's not just a linear increase in the recommendations within each of these groups, because all of the recommendations we have suggesting to use or do not use these recommendations started out as only research recommendations because of the small amount of studies or data to start with. And as this data accumulated, we found out whether they were worth using or not using. And here's just a quick example of one of them. So this is convalescent plasma for the treatment of COVID-19. We included our first study and published on the 18th of June last year. It was a small study with only 103 patients. And so we obviously said, don't use it outside the context of clinical trials. There's not enough data available to determine whether it works or not. And we had 4 additional updates before the end of the year, resulting in just over 1,300 patients. We were seeing quite a strong signal saying, hey, maybe this probably doesn't work at this stage, but the certainty was still low, and we weren't sure if what we were seeing was close to true effects. Whereas come the 1st of April, and the recovery trial published their data for convalescent plasma with over 11,500 patients. And this demonstrated, along with the additional data we had, that there looks like there's no benefit using convalescent plasma in patients with COVID-19. And hence we changed it to a do not use recommendation. And so the question is it achievable and sustainable? Well, we've done 60 guideline updates since inception of the guideline, of the task force over 62 weeks. 40 of those have been major updates. All up, we have 141 recommendations at this stage covering treatments, prophylaxis, respiratory support, pregnancy and perinatal care, and child and adolescent health, among others. And so I think from my perspective, I suppose it is sustainable. This is a very, very, I suppose, I wouldn't say chaotic, but very high throughput, very intensive living guideline. And we've managed to maintain this quite nicely without any significant stress. We've had strong engagement and support from all 32 of our member organisations. So you'd imagine after 14 months of constant meetings and constantly coming up with recommendations and so forth, there might be a bit of fatigue, but they're still very, very much engaged and very supportive of what we're doing. Government and philanthropic organisations and also the public have been very supportive of the task force, which is good. And we've had quite a bit of international recognition and collaboration as well. So we were, NICE reached out to us recently and asked if they could adapt our guidelines for their guidelines. And so we've been working closely with them to kind of build up the UK guidelines as well. The Japanese Association for Acute Medicine has also utilised our guidelines as a foundation. And it's just been fantastic, I must say. So for us, I think, even NICE now is moving to more of a living evidence method, and just living evidence methods themselves are being far more readily adapted and used globally at this stage from what we can see. And so I'll end here and I'll hand you over to Kelvin to share his experience in developing and maintaining stroke guidelines. But if you do have any questions, then please feel free to ask them, and we'll get to question time after Kelvin's finished talking. So thank you.
Excellent work. Thanks, Heath. Let's just bear with us while we swap over. Now, can everyone see that?
You just need to change into your presenting.
Yeah. It'd be good if I could find my own slides. I can't actually see my own slides.
If you exit go out of full screen option for Zoom, if you go up the view options, you can go exit full screen. It should be behind your Zoom.
Yeah, I was out of, sorry everyone. Why don't we just, while I sort myself out, can we put up the first chat question?
Yep, I can do that.
Let me just try this again.
I'm just going to launch the polling, and this is our first poll. And we want to know who is considering living guidelines model in their organisation. So we have 3 options: yes, no, and for those that might not know, even though we've just had the fabulous Heath White talk about it, what is a living guideline model? So that's for those that don't know. And also within the chat, feel free to put why you're considering what a living guideline model is more appropriate for your organisation, and also why you're maybe not considering it whilst we do that. So we've got 33 people. Can we get to a total of 61 members to be involved? And Kelvin, you just need to change out of your presenter screen.
Oh, okay, good.
Excellent work. Yes, I'm now going to end the polling and share those results. There you are. Are you able to see those, Kelvin?
Yes, hooray. Okay, so we would assume, given that you're in this webinar, that you are interested in. So that's fantastic to see. So Heath's given you a really nice overview as to why we think living guidelines is a really important thing. Can we close the, we can stop closing, great. Just before I start, just again, acknowledge welcome to country. For me, it's the Awabakal people here in the Hunter Valley. And my conflicts of interest, like Heath's, really don't have any conflicts apart from being a huge advocate of living guidelines. So I am employed by the Stroke Foundation. This is my baby, this is our work. So I'm talking about my work, but apart from that, I don't have anything else to declare. So just as context, guidelines such as ours have been around for a long time. So we did our first guideline in 2003, working within NHMRC approval. Normally a guideline update for us took 2 years. We've got a large number of people involved. We've worked collaboratively with people overseas to share evidence tables, etc. But it's still frustrating for me that we are looking at the same stuff and it's inefficient. Historically, it's just been static. So you can see in 2010, that's the PDF that was interactive online. It was woohoo. But then when we did our 2017 update, we moved to using an fully online published version via the Magic app. And we also transitioned at that point to use Grade. So that's the background. The living guidelines was really the first. It was the guinea pig out of all of the living guidelines. We started 3 years ago, so in July in 2018, through a project funded through the Medical Research Future Fund, in partnership with Cochrane Australia, which has been really amazing to work with them. And they've really sowed the seeds with the living evidence, living systematic review pilots that they did prior to this. So for stroke, we have 108 clinical experts and 28 lived experts involved across 10 working groups. So not quite as big as the COVID task force, but a massive undertaking just to coordinate that number of people. We also have a massive guideline. So we're quite unique in that we cover 90 clinical topics. So a really broad range of topics. Importantly, we do a slightly different model to some of the other guidelines. We rely on published meta-analysis, so we don't actually undertake our own, and that allows us to do a wider scope of work. So stroke really led the charge, even though diabetes then published before we did. In some respects, it's been led here in Australia, this work, stroke, diabetes, and range of topics. So just to give you a snapshot of what we've changed over the last 3 years. So just about every topic in the guidelines has had some text, whether that's background or the evidence summaries updated. We've had 4 major updates and 26 newer updated recommendations. We've also added, pulling my hair out, losing my hair, 7 additional topics on top of the 90 because we didn't have enough things to do. But importantly, one of the questions that we had when we set off is all this flipping and flopping around, getting new evidence, meaning that we might, 1 month have a strong recommendation and then the next month be a weak recommendation because something else gets published. Importantly, nothing in our guidelines has dropped back from a strong recommendation to a weak recommendation. You can see on this slide, don't worry about the detail. We've had 12 new weak recommendations. We've had two strong recommendations. We've upgraded the strength in 4 topics. We've downgraded the strength that was a weak 4 to a strong against. So that's one case that it did have a significant impact. There was 2 very large multinational trials being published at the same time, and that completely changed the evidence base for that one topic. And we've updated 7 others, but without changing the strength of the recommendation. So it's important to note, yes, there are changes, but there would be very few times where we would go from a strong recommendation back to a weak or a weak against. So here's a case example, though. Heath, if you listen to Heath presenting and the COVID Task Force group, you sort of melt down being a guideline methodologist because you realise how much work they do in such a short time. It's an impressive demonstration. For us, we moved from obviously we've updated our guidelines every 3 to 7 years. This happened last year where we had a major Australian-led trial published in May, and then there was 2 previous randomized control trials combined in an individual patient meta-analysis that was published the month after that. And so we rapidly reviewed that information, consulted, had a draft out within 2 months of the original published trial, and we have an updated approved guideline by November. So you can see the timelines for an update has moved from years down to literally an approved guideline within 6 months. And that's sort of the best case scenario. I think that's a great demonstration that it is feasible. We've just recently completed, so we're literally coming to the end of our 3-year project. So we've done an independent evaluation considering the acceptability, the feasibility, and the early uptake of the living guidelines for stroke. We did a mixed methods approach, surveys and interviews, focus on 2 groups. So we talked to those that were involved in the development, the clinical and consumer experts. We also did some surveys and interviews for end users. We've also looked at the project team. So we've collected data on how long it's taken us to update, how many searches have we reviewed, what's the yield for that, and I'll present a top line information of that. So just at a development group, we had 50 people participate. So this was over a third of all those, including my project team, the clinical experts, the executive team, everyone involved. So there was 50 people, 14 of those were interviewed. Overall, the very strong message was this is an actual positive experience. So it was rated as good or excellent by 83 people. What worked well, what people told us, and Tari, I think, is probably online. She's always, for many years, reiterated people and process. So if you have really good coordination and you've got good people involved, then it's more likely to be success. And that's certainly what we were told. So effective communication with the project team and coordination is critically important for living guidelines, probably more so than a traditional guideline. What was really important, though, for this group was that all people were involved, and we had a really big emphasis on consumers. So having 28 people with lived experience, each one of those was paired to every topic in the guidelines and worked side by side with our clinical experts when we had a draft update. And so that inclusion across multidisciplinary, including the consumers, was viewed very positively. It was also the consumers themselves that it was great that they could focus on areas. So we allowed them to focus on topics that were of particular interest to them. And the same with the clinical experts. We didn't say, we need you to do this topic. We said, what's the area that you're most interested in? And there's obviously a shared workload and collaboration that happens around any guidelines, but particularly in this guideline. What worked, what we could improve on? Clearly the pandemic did have an impact with us. So we were very conscious not to over Zoom people, and we probably went the other way and just emailed and relied on that more than Zooming. So we probably could have had more meetings, strangely enough, but the consumers also probably would have valued a little bit more engagement. The consumers also said it'd be nice to have some adapted content for them, and there's a project underway that we're doing now, specifically taking the recommendations and adapting it to consumers. And just then balancing the workload. I don't know that we can change any of that, but I'll talk a little bit more about that in a minute. So just thinking about the feasibility from a project team point of view. So unlike Heath, where there's the 3 criteria for what should be living, our exec made the decision to see if we can keep all of our topics updated. We're just killers for punishment. That's fine. So we basically did one big search, did a big funnel of all things that were published in stroke that were randomized control trials or systematic reviews, and we screened that every month. So we found that about 350, so Steve McDonald helped us with a really sensitive and specific or pragmatic approach to detecting what we think is about 98% of all potential relevant new trials. We find about 350 to 400 abstracts come every month. That might increase, obviously, as things get published, but it's certainly that bite-sized chunk compared to the last update that we did. We screened over 110,000 abstracts. So you can see just, again, that graph that Heath showed early on, doing small rapid changes and reviews rather than the big workload drop off, the big workload we think is more sustainable. So on average, and we have gained some efficiencies over the time, but over a 9-month period, we averaged 16 hours of time for our team to screen and identify trials. That's not necessarily extracting or doing the actual evidence, the grade profiling, drafting new recommendations. This is just the surveillance component of the guidelines. So 2 days a month. And out of those 350, we had about 17% that we then talked to our clinical experts to get advice about whether they felt that new information would change or potentially change the recommendations. And we used very much an engaged approach with our clinical experts to determine the threshold. So Heath talked about the threshold, the decision making for if the new information is likely to impact on the recommendations and therefore make decisions and workflows based on that. So 17% potentially eligible, of which finally 2.4% of all those screened were summarized and included in our guidelines over that time period. So I think that's a fairly realistic but quite useful yield, and taking a couple of days a month is quite achievable and sustainable. What about our end users? So we actually ended up having 178 people respond to a survey, of whom 15 people were then interviewed. 86% of those in the survey were aware of the living stroke guidelines, and 3/4 of them having used them, so referred to them. Most people felt that, well, just about everyone felt that it covered all the important topics, which thank goodness, because it covers a lot of topics. But importantly, this graph, I think, to me, is the most important data that we have in the evaluation to date. So we asked the end users a series of questions. Do they trust that the living stroke guidelines now more than the previous static guidelines? Overwhelmingly, people said yes, we have increased trust in what's being recommended, and that's pretty clear to see. 70%, and half of that, so if you break it down in small increase versus substantial increase, it's about 50-50 split. So there's a large percentage of people said, yes, I trust the guidelines and what's being recommended because I know it's constantly being reviewed and updated. And I think that's important from a clinical end user. They also reported a higher likelihood to access or refer to the guidelines and to refer to them more frequently. So you can see, again, over 60% or approximately 60% said because they're living, we're going to access them more often. And then importantly, the intention then to follow them was high as well. So there's obviously people who say we won't change because they're all over the evidence, and that's fine. But a very high percentage said that they, because of the trust, because of the frequency and updating, that they're likely to follow it. I think that's a really important message for us. So we also have looked at website, just Google Analytics, as people do. So over the last 5 years, so 2016 when we first started using Magic in developing the 2017 update, we've had an over 300% increase in the users on our website and almost 400% increase in page views. So you can see clearly when we launched the guidelines online, we had a big spike, and then we've had spikes in between, often related to when we've pushed out either consultation or the final updated version. Peaks and troughs, but clearly there's a great demand and accumulation of people searching for information. So I'm just going to pause here. Danielle, can you put up the second poll, please?
The poll is launched. Is everyone able to see the poll?
Yep. So Heath gave his some of his challenges. I'll reiterate some of them, but I just wanted to see what you guys think or have experienced as the challenges for living. You can choose more than one option, so go to town. We'll give you 10 seconds.
We're getting some great engagement on the poll, Kevin.
Excellent. Give you another 5 seconds. Get your votes in.
I don't think we're going to be surprised about the leading one.
Okay, good.
But everything else would be, I think, interesting.
All right, let's have a look.
Are you able to see those results?
Yes. So funding, good, absolutely. Defining scope, managing content steering groups. Yeah. Look, there's lots of challenges. Thank you, Daniela. So what we found as the challenges for the stroke is we've got some really good enhancements with the technology. It's just not all linked together efficiently yet. It's the next piece of work that we want to do. So again, we use Covenants for our screening, and then we interacted with our working group out of a traditional Excel file, and then we've gone into Magic. So just the streamlining of that and the familiarity and comfort of a whole big workload of people. Some people were very comfortable going into Magic, making comments, tracking changes. Other people couldn't orientate themselves to it. So there's still some challenges with the technology. Some great enhancements, excellent efficiency compared to historical things, but we still have a way to go. As Heath pointed out, just that threshold and decision making around, okay, we've got this new bit of evidence. What does it mean? Should it mean that we do massive undertaking and extract the data, et cetera? We had three basically flows. If there's no new evidence, then clearly it was easy because there was nothing to change. If there was new evidence, we made a decision with our clinical experts to either, if they did, we asked them a series of 3 things, but if they did say that it potentially impacted the recommendation, we would put into our fast stream. So we would then get my team to extract the data and review it. But if it was unlikely or deemed to unlikely change the recommendation, it might add to the evidence, but it's not likely to change the effect size, et cetera, or our certainty, then we just put that in the slow stream. And we basically said, well, we'll just hold that for a couple of months and see whether other trials add in over the next couple of months to then integrate that with the evidence profiles. So that seemed to work okay. But for stroke, and particularly around the rehab topics. So in rehab, there's trials that are much smaller. There are a lot of them. And so just the volume of trials. So even with one update, which was, I think, about a 3 or 4 month period, there was 41 new systematic reviews for walking across, I think, 13 different subtopics. So just making sense of that is a time-consuming process. And so having some decision rules and pragmatic decision rules about the likelihood of this changing the recommendations and therefore what we do in response to that's been really important. Something that has evolved over this time. We're getting there now, but it's been a challenge. Certainly the timeliness of coordinating input. So when you've got you've got the juggle, you've got 90 topics, we've got 140 people that we're interacting with. So just getting the right feedback in timely May, making decisions, coordinating working group meetings, blah, 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 is a juggle, absolute juggle. Communicating dissemination is another thing. We moved last year to a monthly email summary that we send out to 18,000 people on our email list. And that was positively received in the evaluation, just to give that update to say, okay, what's new this month? Get a snapshot really quickly. But other ways of working with the societies and having different channels that we share that information has been important. The sustainability of the working group, Heath mentioned about this too. Particularly consumers. So the training, the ongoing support, keeping them engaged is a different kettle of fish to a static, defined point in time. And we did a survey on this. How's time? Okay, coming to an end. We did a survey on this about how often the working group felt like they needed to have a decision input. And they actually thought probably don't need it every single month unless there's major new evidence. Probably every 3 to 6 months for stroke might be enough. As long as someone's looking at the literature every month and can respond to those major new trials that obviously are clearly practice changing. So the way that we've engaged, and also the sustainability, having new people come on board before other people drop off has been important learning over this. Funding's not even on the list because I think that's taken for granted, and I'll touch on this in a minute. So clearly the stroke experience, like the diabetes, living guidelines are feasible. Absolutely are feasible. Is it sustainable? It's a funding model and a funding change, but I think it's really important that we've demonstrated now that we can rapidly integrate new evidence into a rigorous process and get NH and MRC approval, importantly, but that the consistency, we're not dropping the time, we're not dropping the ball and having to pick that up, and that's important. So we really want to be casing what we're doing and leading in Australia, but we want to have a world-class evidence system. So in order to do that, and Heath touched on this, we have a group of us involved in what's called the Living Evidence Consortium. So it's got peak bodies from stroke, diabetes, heart disease, kidney disease, and musculoskeletal. We come together, led by Cochrane Australia. So there's 70 patient research and policy groups involved in the consortium. We impact combined 11 million people and a very large cost. And we come together to try and find lasting solutions, and really solutions for this. And living, I think, is an important solution. So we've had a number of demonstration projects. Obviously, stroke's been one, diabetes, the COVID's been another. Musculoskeletal is doing some work at the moment, doing a living network meta-analysis. We're now talking to governments and other stakeholders to say, we've got this we've tested this model, we think it's the way forward, but there's going to need to be a change in the way that guidelines are funded and prioritised in Australia. So we're advocating for the next phase of development, what we call phase 2, around 4 key pillars. So we still think there needs to be that central support for methods and evaluation and development. There obviously needs to be some further enhancements around the tech, increasing the efficiencies, using AI and different methods to really build more and more streamline of that approach, but have an end-to-end sort of suite that people can use. Clearly, we need to keep producing living guidelines, so stroke will continue until we secure further funding. And importantly, just having that implementation is another important thing. So that's also linking with clinical quality registries to monitor the impact. It's about co-design and decision support tools for consumers, and end-to-end sort of suite of products for clinicians. So that's what we're advocating. We have got support from a number of state governments, but we need to get others over the line to actually have enough central funding to make this happen across the board. So if you're interested in living evidence, please have a look at the website, get in touch with us. We'd be keen to talk to you further, but funding is an issue. And until we get government to change the way that guidelines are viewed, but also to accept, and most of the conversations that I think people have had with key people in government is that there's an acceptance that this is the right model. It's just about finding the sustainable funding and agree to that across each state government and federals. So I'm going to end there and we can go to some question and answers.
Yes, we've had quite a few within the chat, which I've just put within your all panelist chat as well. But would you like me to go through them?
Sure.
So Heath, I think a very practical question, and a question everyone is wanting to know, especially us systematic reviewers, is I'd love to know what process you use to get 23 picos down to a manageable 4 picos.
Yes, no, a very good question. I suppose a lot of negotiation, a lot of discussion. As we said, for one of the groups, we managed to do that in 3 weeks to whittle them down. The other one took 7 weeks. There was clearly a lot of discussion back and forth there. I think it's just understanding, and constantly applying the 3 pillars that make or potentially make a recommendation of living. So if the particular question which doesn't quite fit the living evidence criteria, then we can kind of point this out to the panels, and they can decide which ones they would choose based on the living evidence kind of model. Another one is, as a lot of you who develop guidelines are quite aware, panelists or guideline development group members often like to have quite broad PICOs. So they'll say to us, what's the best therapeutic for the treatment of diabetes? And that's a massive PICO, which is a huge body of work. And so we have to kind of whittle it down to have a specific PICO that can address a specific question that's answerable, that fits the living evidence method. So it was a lot of discussion. There were a lot of variants. I think the main body of PICOs were similar to one another, but slightly different variants. And so we just kind of selected the best one, which was most appropriate for the model we were using. So, but it wasn't too bad in the end. So.
And Kelvin, have you ever had to go from 23 picos down to 4?
No, we just add picos. What the hell? We just, So no, we take a different approach, and that's purely because historical reasons, but also we're wanting to have a full suite of recommendations for stroke. Stroke is a complex disease, and there's important elements, and there's been really some major breakthroughs in research over the last 5 years, 10 years really in stroke. So it's an exciting time, and so we wanted to cover. Not limit, I think, to those key core things and try and cover everything. But there is some trade-offs to that. Obviously, not doing our own meta-analysis and relying on others is a downside to that, but it's just the approach that we've taken.
Thank you. So the next question, and we identify this as one of the key challenges to living guidelines, and I'm sure both of you are very well understand this issue quite a lot, and that is the funding structure for living guidelines is different to that of traditional point-in-time guidelines. How do you secure funding structures that support a living format or convince the funding bodies that a living guideline approach is preferable? Who would like to go first on that one? And these are probably our two most experienced people in Australia on how to get funding for living guidelines. So I think we're lucky.
We're probably asking the wrong people, because Heath and I do the work. We don't do the advocacy side of it behind the scenes. But look, I think there's a couple of things here. Clearly, like Heath can answer, but from Cochrane, they've obviously been very supportive, and they're obviously pivoted to do the COVID. So there needs to be, and same with stroke for us, we've had a commitment to produce and provide to our clinical community a good, up-to-date advice. And so, our board, for example, is, even though we don't have ongoing funding, is saying, yes, we can do an interim model, taking on board some internal funding. But that's not sustainable. We don't want to continue that. So there needs to be strong organizational support, so you don't just say, okay, too bad, the project's finished, see you later, because you just lose the core skill of your team. So I think it's opportunistic funding. It's been research funding, advocating to high levels of government, particularly MRFF for us, and being opportunistic. Heath can talk about, COVID or diabetes, but there's no magic bullet for funding.
Absolutely. It is, I suppose, when you ask funders for money to do something that hasn't really been done before, such as living evidence, so it's still very much a kind of juvenile field of research at this stage, but we're getting more and more evidence behind us. Funders are less likely or less inclined to just hand out money to you, I suppose. So it did take some convincing. We've had a fantastic advocacy group at Cochrane Australia and within the Consortium, explaining the benefits of living evidence. And as I said before, I think a lot of funders, if they spend a few $100,000, developing a guideline, and then suddenly a few years later it's outdated and somebody's asking for a few $100,000 more to update it, that could probably be a bit frustrating. Whereas, using this living evidence model and just suggesting that, well, we require a lot less money over time just to walk this plateau and make sure it stays up to date, and make sure that the currency of information is maintained as well. And I think one of the main things as well that has actually helped from a understanding perspective is actually the COVID task force, because it's spread awareness, and clearly it's showing the benefit of living evidence in a critical field of research quite strongly. And I think the government's kind of seen what we've been able to do in the task force, and stroke and diabetes and the other organisations, and now understand that there is benefit in living evidence and that it's worthwhile investing in it to develop it further and expand it. So.
Thank you.
I think it's just finally working smarter. So working across, that's why we've developed the Living Evidence Consortium. So we realise we're all going to speak the same language. We're all advocating to government together that this is the right way. So I think joining together and making it clear. We've also had really good engagement from NHMRC, who there's a lot of money pumped into new knowledge and new evidence, but it's the translation, and guidelines are an important tool around translation. So it's just knowing where the bits in the system and the opportunities are to really make that key message through government on multiple levels. So
that also brings us to, I think, the relationships that are so important to develop when you are developing guidelines, and Kelvin and Heath, you've spoken about that both in your presentations. So one of the questions we have got is, do you have a strong relationship with the groups doing the systematic reviews to help you plan and schedule your living guideline review? I think that's more directed for Kelvin and his relationships.
So it's a great question. So we've got a number of, we've been very fortunate. We've got a really good working relationship with the Cochrane Stroke Group, and we have a number of key authors here in Australia on topics. So that's obviously, if we know that there's a high quality systematic review that's been published, we integrate that rapidly. That it's easy to see where it is in the pipeline with Cochrane. And we're actually trialing. We didn't quite get to it, but we've got an agreement that our Australian-led authors for one of the depression Cochrane review is going to become going to test out being a living Cochrane review, and that will automatically feed into the guidelines. So yes, it is a collaboration. I think diabetes probably has some good experience, Heath, with international collaboration too, and the challenges with that has.
Yes, we did have discussions with a few international organisations at the inception of the demonstration project. It was quite difficult because our understanding of what constitutes living varied somewhat. So their thought was, well, if we can have this finished, within a year and a half, then that's good enough for us. And we thought, well, no, we need that finished a lot quicker than that. And so there's a bit of a disparity in what they constituted as living and how quickly they wanted to move compared with how quickly we wanted to move in particular. But I think we've worked really well. Again, we've collaborated with a group in New Zealand looking at the therapeutics and diabetes, and with an individual within Monash University looking at the tech side. And they've been very supportive of the whole living evidence method and have actually joined up, I suppose, with the consortium and are pushing forward to develop living guidelines themselves. So it's really been beneficial.
So just a more of a practical question, Kelvin, what were the 3 questions you asked your experts again?
Okay, so one was, does the new evidence change the effect size? So is there a substantial change in the effectiveness of an intervention? Secondly, was there different subgroups or different populations that had, was this new data, so separate to the existing data that is new that we need to consider? And thirdly, were they aware of or recently or to be published evidence that means we should hold off a month or 2? So if there was in acute care, it's a bit easier. Is there a major drug trial that we know is going to be presented at an international conference? And we would then hold off. Rehab's a bit different, but yeah, they were the 3 questions.
Thank you. We're getting quite a lot of questions and we actually have time to answer this, so I'm very excited about this. How do you influence research in gaps in evidence when there is no evidence? And I think that's an important question for both of you.
I think we've all been quite frustrated as guideline developers in not having the evidence we need to actually make the recommendations we want to make. But unfortunately, as you know, we're quite hamstrung in the ability to actually affect change in research, generally when we publish guidelines. I think living evidence gives us a little bit more impetus to actually change what we do and to develop research around those gaps in knowledge. So historically, if you develop a traditional guideline and publish it, I suppose, then it might kind of hit the front page for a few days and then people question, well, why don't we have evidence here? And there's a bit of a furor about gaps in evidence potentially. But with living evidence, we can kind of constantly reinforce the fact that no, there's still no evidence here, there's still no evidence here, and just make it quite clear continuously that we don't have the evidence and point out that it would be clearly beneficial if we did have the evidence. And hopefully that might affect research and some change moving forward. But again, it's limited to what we can do with regards to actually getting the research done in fields where there are gaps.
In the model too, absolutely. So in the model we have, in the whole, if we talk about ecosystems, the evidence ecosystem, living guidelines, as he said, is really an important driver to identify gaps and then push that back through things like prioritizing new funding opportunities, whether that's at a small seeding level that we do at the Stroke Foundation, the Heart Foundation, or other research groups, or NHMRC, having that as high on the agenda, so it actually there is better allocation of resources to where there is gaps moving forward. We hope that that's an important loop in the whole process, feeding in to develop the most appropriate evidence in the future.
And Kelvin, this question, you did say that this was essentially one of the questions you asked experts, but I wanted to hear from both of you about, are clinical trial registries useful to predict emerging evidence and prepare a program of reviewing?
It's a great question. For us, we've just got such a big scope that to then look at the registries. Often the panel members that we have, they're all key experts in their field. They'll know the big trials that are underway and when they're likely to publish. So we rely on just our clinical experts to inform us rather than include the trial registries upstream to identify what's coming out. It's too big a work for us as Stroke. Heath might have different opinions to that. So I think it depends on the guideline.
Mhm. No, I agree with diabetes. It's good to flag those large studies that are expected to be published soon, even though obviously you never know when the data will actually will be released. For the task force, it's been a little bit different. So originally we looked at the clinical trials registries, noticed there's over 1,000 RCTs of various treatments for COVID-19, et cetera. And we used to kind of look at those as in, when will we have to make a recommendation for treatment X or treatment Y? Whereas because we do move so quickly and we're searching every single day, effectively when something is published regarding one of those trials, usually we capture it within 24 hours of publication, and then we can act on that straight away. So kind of predicting what's on the horizon is not really beneficial, I suppose, for the task force perspective, because we move so quickly anyway.
So we're at the end of our webinar, but our question that we posed at the start of the webinar is living guidelines sustainable and achievable? What do you think, Kelvin and Heath? I think we've got our answer, but to sum it up.
Yes. All right, well, I think it's definitely feasible. The sustainability comes into the funding question, so that's a bigger system-wide issue, but certainly it is feasible, and I think our evaluation is small bite-sized chunks more often is more sustainable for our working members than one big job once every 5 years.
Absolutely, and I agree. I think it's very achievable and also very sustainable. And just one last thing before I do go, just to let you know that the Task Force Infection Prevention and Control recommendations for our protection of face masks have been published as of less than 24 hours ago. So we're very pleased that that's actually out there now. So please hop on Magic App and have a look at the diabetes and stroke guidelines and the Task Force guidelines and the infection prevention and control guidelines too.
Thank you. So we'll wrap up the webinar there, but I just wanted to highlight that we are part of the ANZ Guideline Network and the ANZ Regional Steering Committee for the Guideline International Network. Now, within the chat, I just realised I put that to all panellists. Please go to that website and you can sign up to our mailing list, but also find areas that you can contact myself, Kelvin and Heath, and we'll be happy to answer any questions that you may have. And the webinar recording will be up on the Guideline International Network YouTube page, hopefully within the next week or two. So thank you so much for coming. Thank you so much, Kelvin and Heath, for your time and your expertise in this area. It is much appreciated. So I'll be closing the webinar now. Thank you.
Thanks.
Cheers.